Good morning, good afternoon, everyone, and thank you so much for joining us today in what is the first in the series of policy dialogues that the Partnership for Maternal, Newborn and Child Health is hosting to discuss what will it take to accelerate action to reduce maternal, newborn and child mortality. Colleagues, we are all aware that the global maternal mortality ratio has stagnated since 2016 at around 223 maternal deaths per 100,000 live births. Only one WHO region, that is the Southeast Asia region, has recorded a significant decline in maternal mortality, while all other regions have recorded either a stagnation or an increase, according to the World Health Organization. This figure is still over 3 times higher than the targeted 70 maternal deaths by 2030, according to the Sustainable Development Goals. 46 countries are projected to have a ratio greater than 140 maternal deaths per 100,000 live births. Every day in 2020, almost 800 women died from preventable causes related to pregnancy and childbirth. One maternal death every 2 minutes. Evidence shows that this number increased in many countries throughout the COVID-19 pandemic. Over 70% maternal deaths are due to obstructive causes, including postpartum hemorrhage, hypertension, sepsis, unsafe abortion, and embolism. The death of women in childbirth shows a profound pattern of discrimination against women, which starts with discrimination against girls and ends with them dying in childbirth. Reversal in progress made at the end of the Millennium Development Goals is starting to reverse. Intersecting factors, which include weak health systems, poverty, conflict, displacement, political instability, and legal and policy restrictions on sexual and reproductive health information and services, result in significant disparities in access to life-saving care for women and girls. As we approach 2030 deadline with only 5 years remaining to achieve SDG goals, the global community must act decisively to accelerate progress. With the renewed global commitment enshrined in the World Health Assembly resolution earlier this year, it is crucial to focus on scaling up services and interventions that have the most significant impact on reducing maternal, newborn, and child mortality, particularly in vulnerable communities in fragile settings. Evidence shows that those communities that have dramatically improved their maternal mortality rates did so by addressing a number of socioeconomic factors that cross-pollinate across many other SDG indicators, including neonatal and adolescent mortality rates. This high-level dialogue is a first of a 3-part series that will bring together policymakers, healthcare leaders, and experts to discuss how countries can strengthen and scale up high-impact interventions to accelerate progress towards SDG targets. This dialogue will focus on services and interventions for maternal, newborn, and child health, particularly those to address unique needs of the most vulnerable population. We have identified a few objectives for these dialogues. Firstly, to identify and discuss the most effective services and interventions that are needed for reducing maternal, newborn, and child mortality. Secondly, to explore how to overcome barriers to scaling up these interventions in fragile and crisis-affected communities. Third is to generate practical solutions that can lead to improvement of access to quality services. And lastly, to provide actionable recommendations and clear action to accelerate progress towards SDGs 3.1 and 3.2. And colleagues, with that, it is my extreme pleasure to invite and introduce you to the panel with whom I will speak about practical strategies for strengthening services and intervention. We have with us today Dr. Zoya Ali Rizvi, Deputy Commissioner, Ministry of Health and Family Welfare, Government of India. Welcome, Dr. Zoya. We have with us Dr. Poonam Durdana, the CEO of Khudi Research Center for Development in Pakistan. We have with us also Hafsa Mushid, Youth Advocacy Network leader from Sri Lanka and chair of the PMNCH Adolescent and Young Persons constituency. And lastly, but not least, we have Kathleen Schrutt Helen, the Sexual and Reproductive Health in Emergencies and Humanitarian Division lead at the United Nations Population Fund. Colleagues, each of you will have about 5 minutes to address key issues, which will be followed by a moderated discussion. For those of you joining us online, don't forget to post your questions in the chat. We will be taking up the question and answers in the moderated round later on. With that, I would like to start with you, Dr. Rizvi, and with the question that is, how is India advancing maternal, newborn, and child health services, particularly for marginalized populations, while demonstrating leadership in adolescent health through the Rashtriya Kishore Swasthya Karyakram, the RKSK, and integrating sexual and reproductive maternal newborn health services for adolescents through life course. Over to you, Dr. Rizvi.
Yeah, thank you, Raja. Thank you for the, I think, exhaustive questions. So I think my reply also will be quite in some detail. So I will begin by saying that India has been implementing numerous health programs which focus on reducing disparities in maternal, newborn, child and adolescent health, MNCH, with some kind of targeted support for marginalized and underserved population living in the rural areas, the tribal areas, the urban slums, and the hard-to-reach areas. The efforts made by the country are multifaceted, which span across various sectors. Within the community outreach, we have what we call the accredited social health activists, the ASHA worker, who are designed to bring essential health services directly to the doorsteps of the vulnerable communities. They provide a trustworthy link between the population and the healthcare services. That is our first army which we have. Second is we also have the Ayushman Bharat Long Live India scheme, within which we are establishing primary healthcare centers, which are called the Ayushman Arogya Mandir, the AAM, which are also the health and wellness centers. We have established more than 174,000 and counting now nationwide centers right at the grassroots level of healthcare provision. So these are established to ensure that accessibility of services is there, that there's quality of comprehensive primary healthcare, as well as this package. There's 12 package health interventions which are ensured at these levels, which include the maternal newborn child health, which include elderly care, includes mental health, includes prevention of non-communicable diseases, to name a few. So there's a comprehensive set of services. Next, also, we have been prioritizing safe childbirth practices, skilled birth attendants, access to emergency obstetric care. We have achieved significant reduction in maternal and infant mortality, you all are fully aware, especially in the underserved region. So that is very closely monitored and evaluated by the program division, which looks after it, and the government. Besides this, to ensure that the most vulnerable people have access to services, we have developed digital health initiatives. Example, I just named two of them. One of them is called the eSanjeevani. It's a telemedicine portal on which any person can log in, so give their complaints, their suggestions, I would say, what problems they are facing. And there's a person on the other side who addresses all the problems. And in case of referral, they're also referred to the nearest healthcare institution. Second is what we call the Telemanas, which is a kind of a long distance support for mental health, in which there is absolutely non-judgmental, empathetic support for any mental health intervention. Anybody reaches out for mental health care, so that care is given at various levels. So these are two digital initiatives which have taken, I think, a healthcare reach to a very large extent, huge reach across all the areas in our country. Now, coming to the adolescent health, I would say many of you may have heard about the journey of adolescent health in our country back from 1997, where we had the RCH1 strategy for our country, which talked about just reproductive health care of adolescent girls. We moved towards National AIDS Control Program, in which there was importance of education in schools, which we call the Adolescent Education Program, for educating children in class 9 and class 11 about reproductive sexual health. From there, we moved on to the adolescent reproductive sexual health, the ARSH strategy, which ensured the importance of adolescent health and also included the family health along with that. So from there, I think we have moved a long way beyond that. And since 2014, in which our country implemented the National Adolescent Health Program, which you mentioned, it's kind of a mouthful. We have what we call the Rashtriya Kishore Swasthya Karyakram. Yes, that was launched in 2014, and which actually now represents the national commitment for adolescent health and well-being. So it is looking at not just the preventive aspect of adolescent health, but also looks at the curative healthcare needs of all the adolescent 10 to 19 in our country. And besides that, it also looks at what we look at the paradigm shift. So it moves away not just from sexual reproductive health to add nutrition, mental health, gender-based violence, substance misuse, prevention of non-communicable diseases, but also moves from within the healthcare systems out into the community and schools. Because I think we realize as a government that we have to get these young people wherever they are. So that was one thing which was a huge change for our country. And this is the strategy for the RKSK, which you mentioned. And within the community also, we have the adolescent peer educators who are selected and trained, and they have this open communication within their own peer group, which looks at breaking the stigma and on sensitive topics, especially sexual reproductive health and mental health. And they also support youth-friendly approach to health services, because they refer these young peers who are in need to the adolescent-friendly health clinics which are established. Another thing in community we are also looking at is the adolescent health and wellness days, which are a unique opportunity of celebrating adolescent health within the communities, in which we are talking about sensitizing the various stakeholders and gatekeepers of adolescent health, normalizing talk on adolescent health within communities. So within communities, we have these two interventions main. Within the institutions, like I mentioned, the adolescent-friendly health clinics, which is, I think, the first portal of support for any young person reaching out for help within the health institution, where we have trained medical officers, counselors, or staff nurses to talk about adolescent health. Other interventions, quickly just saying, we have the iron supplementation program to ensure that we break the intergenerational cycle of anemia. Then we have the menstrual hygiene scheme, in which there is promotion of access to low-cost sanitary napkins, and also awareness on menstrual hygiene among young girls, whether in school, out of school. And also within the school, I would say school platform, which I mentioned earlier, is we have a beautiful program called the School Health and Wellness Program, which is looking at supporting school-based interactive activities by teachers themselves. So these teachers are trained so that they act as health ambassadors within schools, and they promote joyful learning within schools, and thereby ensuring health promotion within the school children. So that we believe is a very strong platform which we are partnering with the other ministry to ensure that this is actually implemented. But then I think having implemented all this, there are a lot of learnings, because a country as large as India, with the huge geographical spread and the huge population that we've had our own challenges. First, I would say one of the few challenges which I will quickly enumerate is the importance of, in a country like ours, to have culturally sensitive approaches. What works in one state or one city need not work in another state. So that is very important, to have something in which we say is you tailor the services to the diverse needs of whatever the population there needs. So that is one thing which you're looking at. Second, we said the very crucial importance of community engagement. In any intervention which you do, the involvement of not just the beneficiary, but the entire community, so that they are aware of what the interventions are. Especially for adolescent and young people, for a country like ours, it is very important to take the parents on board. So the parental engagement becomes a really important part to ensure that even the young people who reach out for help, it's a kind of a normal reaching out, and the parents are well in the loop, and they even support the young people in reaching out for help within the public healthcare systems. Besides this, we have also realized as a challenge is the continuous monitoring and evaluation. So whatever interventions we have regular monitoring evaluations, and within the government, we are happy to tweak the programs to support any newer interventions which are shared with us, because states, for us as the country, health is a state subject. So a lot of interventions come from the state. So for us to learn from the implementing states is also a big thing which we do. And we ensure that there's adequate funding, there is consistent technical support, and this consistent, I would say, improvement in the program implementation, which is an important part of program assessment at the national level. Next, I would say also partnership, which I mentioned initially with the other ministries. So there's a lot of stress is placed on partnership with the other ministries, which are also looking at beneficiaries, which may be mother, children, adolescent, young people. So we always try and work with them so that we are in this intervention together. So besides the government ministries, also we have good partnerships with the development partners. I've seen UNFPA join, so they're one of the national partners here with us. We have UNICEF. We have other minor, besides these large UN partners and WHO, we also have the other NGOs who are helping with us, because we have realized that government can reach only so much. So a lot of times the last mile delivery is supported by the community-based organizations or the NGOs who are there, because they come up with new insights, new engagement with the grassroots population. So that is where I think we're happy to partner with them and work with them. And besides just within the country, we're also happy to learn and understand from the various cross-learning platforms which our country has been taking part in, whether it is the G20 or G7, wherever we are a part of the committees, we're happy to learn whatever cross-learning is possible for our country as a whole. It is taken up in a very positive light. And finally, what Rajat, you mentioned about ensuring that we are addressing the needs of healthcare and wellness across life cycle. I would say that initially, like I mentioned, we are ensuring the delivery of expanded range of services closer to the community, which I mentioned at the health and wellness centers, which are looking at ensuring services at the family household level through outreach activities from the field level workers. Second, also is setting up of the health and wellness centers where the package of services, MCH, mental health, elderly care, rehabilitation services, ENTI, all those services are mandatory there at the field level services, and also linking all these referrals with the higher level. So 3 level of services we are looking at strengthening. Second also is that once you bring services closer to the community, it will also help us in improving the service provision, because we will start monitoring much better. We will look at increased coverage also, and then those gaps which have been missing initially will be covered. So there's good monitoring and good assessment of what the interventions are doing. And also by linking the maternal and child health services with the adolescent sexual health, because we realize that it's a life cycle approach which we have to look at as the government. Once we link the maternal child with the adolescent health also, we will look at plugging a huge gap which is there when adolescent becomes an adult and starts looking at maternal health and then child health if they so become mothers. So that gap plugging has, I think, become a very important intervention which we are looking at for the country. And finally, I would say, I would like to end is that partnerships are something which work very strong, whether it is within the government system, so we partner with other ministries, other departments, or it is partnering with people who are outside the government, whether they are partners or NGOs or academia or research institutions. So all this, unless it is strengthened and strong and institutionalized, our interventions cannot sustain and cannot be scaled up. So that is where, as a government, we are looking at strengthening them so that whatever interventions we are planning are sustainable and scalable, so that we are looking at much better health outcomes for our population in the coming times. So that's it from my side, and I'm happy to answer any questions.
Thank you. Thank you so much for that, Zoya. That was remarkable and a lot to unpack in there. And you know, from the emphasis that you brought on the need to strengthen community-based interventions model, along with, you know, improving the 3 levels of care and the intrapartum care that you talked about, but also, you know, the need for ensuring integrated care across the life course and bringing technology to bear to address the needs and vulnerabilities that hard to reach populations and vulnerable groups often face. Thank you also for joining. I understand you do have another appointment and that your colleague will be staying with us, Dr. Deepak, and we will be coming to question and answers once we have had the first round of conversation and interventions from all the panelists. With that, I would like to go to you next, Dr. Poonam, and to ask you, how is the private sector in Pakistan addressing inequities in access to quality sexual reproductive maternal newborn child healthcare, especially for rural and marginalized and low-income populations? And what, in your view, is the role do initiatives like Khudi play in empowering women to access maternal health services to improve the maternal newborn child health outcomes? So over to you, Dr. Poonam.
Thank you very much, Rajat, for providing me with this an opportunity to present something which very important for all of us. And I would request to allow my screen sharing so I can present a small presentation with the group.
Absolutely. Dr. Poonam, you should be able to do that if you click the share screen.
Yeah, it's saying host disabled attendee screen sharing.
Okay, I'm sure the logistics team is working on it, so you should be able to access that momentarily. But why don't you continue with your remarks,
Yeah,
and
okay.
my colleagues will give
Yeah,
you the.
yeah. So, Khudi started an initiative to access equitable RMNCH services by women empowerment in one of the provinces in Pakistan. And during that, since Khudi vision is to enlighten, empower, and aid the compromised individuals, and make their self significant, so that they can play a very vital role in achieving sustainable development goals. So the objective of our RMNCH entrepreneurship model was to enable community midwives so that they are able to identify the qualities, strengths, opportunities, and skills that they already possess for setting up and running their own businesses. Then we wanted them to identify the support structures that may help them to start a business as an entrepreneur. Then we wanted to introduce us to the CMWs the basic concepts of financial management, marketing, and setting up of a maternal fund, which we called as Mamta Fund. Mamta is a Urdu word for maternal. And lastly, we wanted them to be enabled so that they can develop their own business plans for the sustainability of the CMW workstation. So why did we focus on the community midwives? Because for us, it's a triple dividend. It was an opportunity to enhance the capabilities and skills of community midwives within the framework of existing RMNCH practices. Then, because the fundamental role of CMW is to promote and ensure safe motherhood and essential newborn care, and then we wanted effective, we know, and of course, effective resource mobilization through entrepreneurship is and an investment for the future generation. So we wanted them to develop a marketing plan for RMNCH service package so that they're able to understand what RMNCH services are required by mother and children. What are They were advised to develop a package of RMNCH services which gives mother and child what they need and what is actually their want as per their situation. Then they were advised to develop and promote the RMNCH service package to their clients and customers, and then also they keep on improving their RMNCH service package. So they were advised to develop a Mamta Fund, which is a maternal fund for emergency referral services, and it revolved around to address the needs of the emergency obstetric care and the neonatal care, which might arise at any time during pregnancy, childbirth, and the postnatal period. For that matter, they identified a free charity ambulance service, and in case of non availability, they identified a taxi driver in the nearby vicinity as a secondary referral contact who can be accessed in case of need by provision of a very minimal amount for as a fuel cost. And then the total amount of the Mamta fund, which was allocated for one person, was divided by the remaining number of the total months till the EDD of the expected date of delivery of that pregnant woman. And then they were advised, the pregnant women used to make monthly installments during each month to collect the amount required. And after completion of the delivery, if it was a successful outcome without any complications, the money was provided, was returned back. And if during the pace after the postnatal period. Now I have a referral chart to show the how this work, but I don't know whether the screen sharing is okay. It's working. Then the capacity building and development of the RMNCH business plan was done for the setting service fees for MCH clients based on MNCH guidelines and in accordance to the local context and customer willingness to pay. Then basic accounting and budgeting skills were given, setting waivers for those MCH clients who are unable to pay any loan repayment plans, purchasing of ongoing supplies, tracking contributions, and to develop a supply chain in order to avoid any stockouts. They were also provided a biannual support of worth USD 1,000 to 600 to commence a home-based business, which was at their CMW workstation. They can open a grocery shop, a tailoring shop, ladies' accessory shop, sports and toys, and the basic medicine. So these were a few of the items which they had in their workstation. And then marketing, RMNCH marketing messages were developed for the entrepreneur CMWs. And these are the messages which they developed themselves, like no need of going to market. Additional RMNCH services and female products are now available at Bismillah CMW workstation. They were given a choice to name their CMW workstation, so somebody named it, at the name of their children. Somebody named it as like Bismillah, somebody like it was their own choice. Then PPH is a sudden and unpredictable life-threatening condition. Don't take risk and avail the quality service from so and so CMW workstation. We provide Mamta Fund, your safety for prosperous maternal health. This CMW workstation offers quality birth preparedness package. This CMW workstation ensures provision of tablet misoprostol at the time of delivery to prevent PPH. So, how this model supported CMWs and RMNCH? It provided access to health, it prevented maternal and child morbidity and mortality, it established referral linkages, and of course, increased in the number of MCH clients, besides empowering the CMW to have education and prosperity for her family. And for her, we identified lucrative markets with potential for growth and employment creation at her doorstep. And of course, she was able to contribute. You can see the graph. It shows the antenatal care, postnatal care, and the family planning clients. So the green graph bar shows pre the project figures, and the blue one shows the post project figures, which definitely has increased. Of course, there were challenges for the CMW as entrepreneurs in a country like Pakistan, and then in an area like Balochistan. Of course, there are gender stereotypes and imbalanced gender equality, limited choices for women as an entrepreneur, social pressure for loan and credit on services and commodities at CMW workstation, and if the shops are owned by men. Therefore, it becomes difficult to engage with them in absence of a male family member. The project was well appreciated, so it was acknowledged by the Director General Health. These are the letter of appreciation. And then we again signed another MOU for 2024 to 2026 with two provinces in Pakistan for now, for every woman, every newborn, everywhere action plans. These are our partners. We acknowledge all our partners, Government of Pakistan, provinces, PMNCH, Interagency Working Group on Reproductive Health in Crisis, WHO. And now I thank you very much. And if there are questions, I'll be very happy to answer. I have this picture saying, why can't we make a world better place for everybody to live? Thank you so very much.
Thank you, thank you. That was remarkable, Poonam, and for all the work that you are doing. And thank you really for bringing in the emphasis on the need for localized solutions to address the kind of issues, but also, as you very articulately put forward, is linking the economic empowerment models to the service delivery aspects and what a game changer it can be. I'm sure there are a lot of questions, so I'm also hinting it to attendees and participants to get their questions ready. And I'm very glad to also say Dr. Zoya Rizvi from Government of India will be able to stay with us for the Q&A session as well. So thank you, Zoya, for accommodating that. And with that, I would like to now come to you, Dr. Hafsa, and ask you in terms of your experiences, in terms of what we can do in terms of addressing the kind of sexual reproductive maternal health challenges that you have encountered in Sri Lanka, particularly looking at the work that you do in terms of with youth-led grassroots movements and organizations to achieve meaningful engagement of young people in ensuring that adolescents are prioritized in comprehensive healthcare services package. So over to you, Hafsa.
Right. Thank you, Rajat, for this opportunity. And it's been such a pleasure being part of this and listening to the interventions that is happening in South Asia. So I just want to start by saying, in terms of public health care and maternal well-being, equity has been like the cornerstone in terms of Sri Lanka's health policy in that angle. And the government has prioritized maternal and child health through evidence-based interventions. So for example, in 2016, they conducted the demographic and health survey, which actually provided a lot of data which has informed the current health policies and programs that is run, and which led to the implementation of the Safe Motherhood Initiative, which was launched in 1998. And we have been able to improve the maternal mortality, which has decreased from 92 per 100,000 live births from 2016 to 29 in 2020 due to these interventions. So some of the examples I want to highlight is the Health Sector Development Plan, which was launched in 2021, focusing on the period until 2025, which was to enhance reproductive, maternal, and child health services, especially in underdeserved areas. And there was a national quality policy for health services launched in 2023, which sort of acts as the guidelines and standards to ensure health quality services. So I would like to give some examples of how integrated health service clinics has helped in Sri Lanka. For example, it allows women to access care, family planning, child health services all in one visit. So comprehensive prenatal checkups, immunization for their children, family planning counseling, and even adolescent health information can all be covered, and support can be obtained in a single appointment. Then the mobile health unit programs initiated in 2017 helps to deliver integrated health services to remote areas, and they provide maternal health checkup, child immunizations, reproductive health services, reaching a lot of populations otherwise that would have very limited care, and this has increased maternal health service uptake by over 30%. When we talk about adolescent friendly health services, including school health programs that provide reproductive health education to adolescents, and across the Western province have implemented with certain schools successfully, covering topics like contraception, STIs, and healthy relationship, because currently the school curriculum officially does not cover comprehensive sexuality education. And community health workers have played a crucial role in actually integrating care delivery for rural areas. For an example, they have increased awareness of maternal health services by conducting home visits, leading to an increase in institutional deliveries in Sri Lanka. In terms of the digital health initiatives, the digital health strategy was launched in 2022 to improve data collection, and mobile apps have allowed women to track their pregnancy and receive reminders. So we have something called the maternity app, which helps pregnant women monitor their health and access relevant services. The quality assurance in health services program started in 2018 and actually had state standards for integrated care delivery in health facilities, and hospitals are assessed on their ability to provide comprehensive maternal and adolescent health services. So for an example, the Lady Ridgeway Hospital in Colombo has implemented protocols for integrating services, which has improved patient outcomes and high satisfaction rates. If I talk about the role of youth-led organizations like Youth for Health, which was launched in 2015, empowered adolescents to advocate for their health needs. And for adolescents, the Adolescent Friendly Health Service Initiative began in 2004, and it was completely youth-led that led to the success of such initiatives. And even NGOs like Family Planning Association in Sri Lanka engage with vulnerable populations and co-lead with young people to drive certain initiatives. I will give some examples. In terms of the Family Planning Association, their youth program focuses on providing sexual and reproductive health education. So in 2019, they launched the Youth Health Program, and they have a Youth Technical Advisory Committee, which conducts training sessions for peer educators and workshops on reproductive health rights. And this program continues to reach thousands of adolescents each year. In 2011, there was an initiative that was designed and implemented in 2020 called Manasumana, which was about addressing mental health challenges faced by young people during COVID-19 pandemic. So this, because in Sri Lanka, it is extremely stigmatized topic, and access to services become very challenging for young people. So this really helped address a lot of things. The National Youth Council of Sri Lanka advocated for youth health policies, and in 2023, they organized a national conference to discuss the integration of adolescent health services into the primary healthcare system, which resulted in actionable recommendations presented to the Ministry of Health. So these are some of the examples that has been there. The other example that I would also like to highlight, where Sri Lanka is a country which has criminalized access to safe abortion. So there are organizations like Youth Advocacy Network Sri Lanka continuously working with policymakers to work towards access to comprehensive sexuality education, and also raise awareness on the need for access to safe abortion. So apart from that, the digital health strategy introduced in 2020 has, with the Family Health Bureau, which is part of the Ministry of Health of Sri Lanka, has incorporated feedback from young people to enhance mobile health application and services. And this has helped increase responsive rate by 30%, so that the services meet the actual needs of young people. So I'm going to stop here and keep space for questions. Thank you.
Thank you. Thank you so much for that, Hafsa. And it's really outstanding, the work that you are doing, but also very, very interesting example on how the policy legislative approaches are brought together with technological solutions to address the complexity of challenges we face, and in terms of developing the one-stop shop care models that are so vital. And one of the things that we have heard repeatedly through the previous remarks is the need for context-specific solutions. And what do we do when the context is that of a humanitarian emergency, of conflict or crisis? Catherine, you are an expert with decades of experience working on these issues. So could I turn to you next for your reflections on what do you think we need to do in terms of developing data-driven approaches for improving the maternal newborn health outcomes to ensure services reach the vulnerable populations, particularly in humanitarian and fragile contexts, and how is UNFPA supporting such countries and contexts to strengthen national health systems to deliver high-quality SRH services, particularly in the fragile and vulnerable settings? Over to you, Catherine, and welcome again.
Thank you very much, Rajat. And I would like to start by thanking the opportunity to be part of this panel and thanking the participation that I see is very numerous, highlighting the interest in the subject. Maybe starting by the overall UNFPA and then zooming into the humanitarian efforts. As probably most of you know, UNFPA has a very ample presence supporting about 156 countries around the axis of the 3 transformative results. So very clearly impacting on the reduction of maternal mortality, the coverage of modern contraceptives, and then the elimination of GBV in all its forms. I think it's important to remember that there is, on the development side of UNFPA, already a huge effort to strengthen the health system. And I'll come to the importance when we talk about humanitarian in just a little moment. Those axes of work include, of course, the reinforcement and empowerment of midwives as key agents at community level, and that make a huge difference in the well-being of women and girls, and particularly in supporting women and girls when they're pregnant and after pregnancy, and looking out for the newborn. It's also a key partner. UNFPA is a key partner to governments when it comes to supplies. Now, much focus has been given in the past on family planning supplies, but I would like to underline that there is an increasing effort to expand the amount and the type of commodities that can be obtained through the UNFPA supplies, particularly through the supply partnership, and helping governments to have access to the underused molecules. For example, when we look at postpartum hemorrhage, so heat stable carbetocin, tranexamic acid, and that effort is actually growing. I'm not the best place to talk about that. That's really Ayman, who was initially invited, or Michaela. But we have a lot of collaboration ongoing, and there is a lot of work ongoing to strengthen UNFPA capacity to serve as a supply channel to governments. I would like to take the opportunity today to profit from my position of working in humanitarian aid as an SRH and emergency specialist. It is, I think it's my privilege to share some of the reflection that we think as a community would make a huge difference. As you know, the large burden of maternal and newborn deaths actually happens in fragile settings and contexts which are affected by humanitarian crisis. As such, we're looking at a situation where already fragile contexts have a humanitarian crisis piggybacked on them. And what is difficult at a lot of times is to make this shift from the normal situation of dealing with the suboptimal, because we're suboptimal in a lot of contexts when it comes to SRH services, and then shifting to a mode of emergency response. So what I'm trying to say is, in a lot of the contexts where we're working today, the minimum initial service package for SRH is actually even though there's no crisis, not fully established. There's pieces that are established, maybe the EMONC, and then we haven't looked at the quality. But overall, the MISP in a lot of places is not fully there. If you add to that a humanitarian crisis and you come in with, the international leverage, you expect international standards to be put into place. So we're in an odd situation where before the crisis, the indicators have already been pretty low. And then you come with the international support and localization support, but a lot of money, it means coming in. And we're looking at a situation where we want to uplift the situation that was fragile before to something that is close to international standards. In order to do that, we really need the mind shift to say the system is in place. Nobody's questioning the SRH sector coordination. But what we do really need to reinforce is SRH and emergency coordination under the global health cluster as a visible and very well identified, funded, and coordinated part. We established together with WHO and under the global health cluster in 2022 an SRH task team, trying to be the hub and the support to SRH working groups within the countries and under the health clusters, which is the humanitarian architecture. We initiated last year a baseline assessment to try to understand how SRH coordination is functioning. And we found that only under 50% of the health clusters have an establishing and fully functional SRH working group in the country. Now, we think that is really a point that we need to take urgent action on, underlining the full commitment of WHO and UNFPA to institutionalize this SRH working groups at country level in all contexts where there's an activated health cluster, to make sure that we have the capacity to pull in all the actors relevant to making a difference for SRH. We also need, to a certain extent, the interagency steering committee to acknowledge that SRH in emergency is an area in itself that really deserves attention. And that's something that if you look at the different things, GBV under the protection cluster has that. It doesn't need to be a subcluster, but there needs to be a specific mention of SRH, elevating that and making sure that it's systematic and never forgotten. I would just like to highlight one thing that is underway. You know that the UNFPA mandated by the Interagency Reproductive Health Working Group manages the interagency reproductive health kits that allow the implementation of the MISP in humanitarian settings or beyond humanitarian settings. That kit review has just been finalized to have a version 7 of the kit. It's a technical working group of 86 people from all organizations and agencies that have supported that and that have ensured that innovative approaches and underused molecules like heat stable carbetocin, TXA, looking at the drapes, objective measurement of blood loss for PPH, that all of those will be in the new version of the kit so that we can also work on this very preoccupying area of postpartum hemorrhage, which is reflected in the PPH roadmap. I'll come to that in a second. There's urgent need, and Rajat, you underline that data. We know that maternal mortality is happening. We know 15% of women at least will have severe complications, but we have a very hard time to come together as agencies and agree on basic indicators. It seems that it should be straightforward, but it is a struggle. At the moment, WHO is leading a process for these SRH indicators in humanitarian settings. Process started in 2018 and is coming very close to closure together with other agencies. It is going to be a huge step forward if we all talk the same language and collect the same data so that we can really give visibility to these women that die but that are not accounted for. Finally, maybe I wanted to say one more thing. There's also an effort going on between IWAG and UNFPA and WHO regarding the alignment of what is called the H3, the high impact health initiatives in humanitarian settings, to make sure that that H3 as a subcomponent to the universal health coverage idea is actually aligned with the MISP, so that for people in the field, we make it as easy as possible, that there is one set of thinking, one set of key actions, one set of indicators, because even if we try to align, and having been in the sector for 30 years, it is not that easy when you're on the field to understand all these different dynamics and all these different supports that are potentially available. Maybe an action that I wanted to underline that I think really needs support in the future. You know that with the PPH roadmap, there's big projects underway that have support, such as the Amplify or the Safe Birth Africa that UNFPA, Unit 8 and JPIGO are leading. There is, in my opinion, an urgent need to also look at what do we do for PPH in countries like the South Sudan. It's not that South Sudan has a humanitarian setting. South Sudan is a humanitarian setting. That is where we have the highest maternal mortality worldwide. Another example is the Central African Republic, where a large part of the country is a humanitarian settings. And we have to convince donors and convince ourselves that the humanitarian architecture that is created at interagency level is strong enough to be leading efforts to roll out PPH support, strengthening with training, with the new molecules, with the new things like the objective measurements of blood loss, and that we cannot drop these countries, because in 5 years, very likely they'll still be in the same situation. So if we don't invest now with innovative approaches and using the network of NGOs that support the government in service delivery, then in 5 years, the maternal mortality is not going to be better, it's going to be worse, and we won't get to the SDGs. So my appeal in this role is really to say, we need to continuously strengthen the foundation through development work, because the foundation on SRH in many contexts is not solid enough. But we also need to find innovative approaches to immediately bring alleviation to the contexts that bear the highest burden, and those are the humanitarian contexts, and invest into coordination, into supply, and into working with our NGO partners, local and international, to make a difference today for the life of women, both regarding PPH and the other main causes of maternal mortality. Thank you very much.
Thank you, Catherine, for those very sobering remarks. And you reminded me something that we have often argued, that resilience and the arguments which call for resilience of health systems to develop the shock capacity to respond to humanitarian emergencies is often a little bit of a misnomer, because the health systems haven't been invested in to begin with to have that capacity to respond to the kind of external and internal shocks that impair access. And that we need to start thinking about preparedness and the development phase more intently than we do often, so that we are having these capacities. Colleagues, we have had a very rich discussion. We have had some questions already which have started to pop up in chat and in the Q&A segment. So maybe what I can do is try and cluster them and come to some of them for the panelists to respond to. The first set of questions that has emerged is the role of artificial intelligence and technology, and how you think it can be used to address, both in terms of circumstances or contexts that there is low health workforce capacity. So can technology be used there for ensuring that lower cadre of healthcare workers are able to perform the functions? There are counter arguments to some of these things. Would it lead to more, deepening of inequalities rather than addressing the kind of access challenges? Your views on that? And then the second thing that has come out in different contexts, and pretty much all the speakers have touched upon it, is the issue of community and community-based interventions, and the role that the community can play both in humanitarian context, but also in otherwise, developmental context to improve access to services. But how do we address the complexity of communities' own challenges, where there are cultural norms or social taboos, which preclude access to a certain range of services, as we know to be very well. So maybe I can go in the same order that we started from. And Zoya, if you have any reflections on either of those questions, we start with you, then to Poonam, Hafsa, and Catherine. Zoya, over to you.
Yeah, thanks. That's a really tough question to start with, but I would still say AI is a kind of a double-edged sword, you know. It is something which can really do wonders if there are last mile delivery issues you cannot access. But on the other hand, we have to acknowledge that a lot of countries do have the digital divide. They have the haves and the have-nots. So even if you have AI, how many people can actually access and use AI suitably? Because AI still is built on experiences of human beings only. And if we are doing away with the whole human factor, there will be lost lot of, I would say, advice and guidance, which will be lost, you know. So we have to see AI with I will not say pinch of salt, but maybe a box of salt and pepper, because you should be really careful with AI, because AI can do wonders in a lot of intervention, especially in fact in our country also we're using chatbots and all to access young people who want to have that kind of anonymity to access services. That is fine, you know, you reach services, but then at least after a certain while there is some place at which you really need to talk to a person, you know, to a medical officer or a staff nurse who can actually give you the right advice. So that way I would say AI is a wonderful thing, but then everything should be suitably tested and then maybe expanded, rather than going all out with AI and to include services to the last mile. Second, you're talking about even data accuracy, you're looking at, and resource settings. Data accuracy for us within the country is important, because all our programs are monitored based on data. So it becomes really critical for all program officials at all levels, whether it is at the block level, district or state level, to actually own the data. And that is why I think there are a lot of gaps in data reporting within all programs, even in adolescent health and school health, there are gaps. But then once the states realize that that is how they are going to be assessed, based on the data only, they will get extra funding or maybe some reduced funding if the data entry is not good quality. So then I think they will also become very accountable. So accountability is a very critical thing which will be strengthened in case we start looking at data accuracy. And that is, I think, I will stop here because I think there are other people also who want to speak, but I think it's important to ensure data quality rather than quantity. So that is something which we are working on a lot with the states nowadays.
Thank you. Thanks a lot for that, Zoya. That's extremely important. And I think this is where, going back to what Catherine was just saying, the need to find that uniformity of data and how we are approaching data becomes extremely important, especially when we are looking at in terms of the fragility of context that we are talking about. I'll come to Poonam, you next, and then Hafsa, over to you.
Thank you very much for a very pertinent question regarding AI, which we are very much considering to pilot with one of our very strong collaborative partner, Deliver RX, and in our programs and projects, because we understand that today it's the need of the day, and we are developing with Deliver RX to public health knowledge vault, because it would be a community-led data hubs to streamline communication and coordination among various stakeholders. It will automate, centralize real-time data collection, and as is shared by the community midwives or any of the frontline health workers. Of course, very much time efficient to access and validate. Likewise, the program managers and lady health workers can access real-time information on their preferred language, because AI will give everybody an opportunity to get the information in their own local language, which at times, of course, translation of English becomes difficult. Moreover, I think AI will also enable people to like the flow of information from, in our case, it's from the union council level to the district, then to the province and to the national level. But since province, like health in Pakistan is a provincial subject now, so the provincial, it will gives a lot of provincial managers power to decide and see how the data is flowing and what, like it's the real time evidence based decision making and data monitoring. It can like automate multiple tasks simultaneously, reviewing data analysis, progress monitoring, reporting, managing schedules, of course, efficient literature review of relevant programs. There can be self-training tools for the lady health workers or the community midwives in their native languages. So these are, and of course, and I would very much advocate for AI in public health, because it is resource efficient. It will give you strategic resource mobilization, and you can allocate your funds on the real-time data monitoring. And it is an efficient mechanism for coordination and automated processes. So beside this, with regard to the data, as you mentioned, data, of course, is a very, all of our programs are based on the data. So when the data is accurately recorded, it can be interpreted, and then you can plan accordingly for a very effective and efficient program. So this is my 2 cents on the AI. Thank you very much.
Much appreciate, Poonam. Thank you. Hafsa, over to you.
Thank you for this question. I won't take too much time because I think valuable insights have already been shared. Just some things to consider, I think, is I do understand Dr. Zoya's sentiments in terms of ethical AI coming in, because this is a lot of sensitive data coming in. So along with integration, the privacy element also we have to realize, because of the different contexts, again, the localized context, we have to understand of how much of, because for some of the regions and communities that we work with, SRHR services, especially, and related, if you talk about adolescent health services and SRHR health services in general, beyond adolescent population is still a sensitive and a taboo topic. Even accessing those services are very stigmatized at times. So when you work with technology, what does that look like in terms of AI? And the second one is the biases that come into the role, because again, it is designed because when you look at certain AI solutions purchased, not a lot of countries and not a lot of communities and public health people can access Western services or technologies. So when you're doing with local context or even Western context, does that suit the local context, the scalability? Because they can, again, only they serve a certain type of population. And if you are locally designed or internationally designed, the human biases that you bring, we already are encountering a lot of stereotyping and biases that comes from AI produced content. So already when you're in a stigmatized location and a culture or a context, especially in SRHR and especially in the nexus of adolescent friendly health services, that is something that must be taken as in, I don't think we can avoid it. This is going to be very mainstream, but at least we have to be consciously aware on how much of integration and implementation and what is our like risk management frameworks that are going to be in place as we tackle it and integrate. Thank you.
Wonderful. Thanks so much for that, Hafsa. And indeed, I didn't, as recent editorial in the Science magazine said, we are looking for technological fixes for problems that are analog in nature. So unless we start addressing the analog aspects, I don't think technology can deliver to address the sort of challenges that we have. Catherine, over to you before we come to the next question that we have.
So I think my colleagues have already addressed a lot of it. I'm like Zoya said, for me, it's a double-edged sword, very much a double-edged sword. And I'll maybe highlight the areas that have not come up yet. Connectivity continues to be a huge issue. So a lot of places which are underserved, there's limited things that you can do directly in those places. Obviously, AI can facilitate the work that we want to do, but the work needs to be carved out towards what you said, the analog thing. I'll take an example. If we think about PPH, the key action that is needed in order to impact PPH is empowerment of midwives. And there's a room for AI. We can have, translate curricula, all of those things, but you still need to address the way they get benefits, the social recognition and social protection of them, their capacity, their skills, the supportive supervision. And then the second piece is the supply. Yes, AI can help with supply, but AI cannot get the last mile. We still have to do that in very traditional way, because your oxytocin still needs to be cold chained and still needs to get to the right BMONC. So I think what I would like to underline, apart from the dangers that have already been mentioned, that we deal with very sensitive data, and as much as we've seen the internet is fantastic, we also see the backlash of it, because controlling data is very difficult once it's so globalized. Confidentiality is a huge issue, especially in context when you have polarized political situations and when getting back at somebody, or you have data on a rape, on a rape survivor or whatever it is, you can imagine. And the last thing, and that's maybe a personal issue, I have seen in my career as a midwife and as somebody who worked for 35 years in humanitarian settings, a shift away from investing into technical people and a shift towards investing into process and IT. And I think it is, I think we've overstepped the balance. I think we don't have enough technical people. And I would hate to see more money going into AI and the salary of midwives still not being addressed. And there still only being one midwife in a BMONC doing 24/7 with the help of her neighbors. I think we really need, as a global community, to take a critical look at how much we invest into IT, IA, and data systems that at the end of the day, sorry to say it, they continue being imperfect. We're constantly updating them, and we end up being slaves to our own systems because they develop so quickly that we keep having to reinvest. That does not mean that I don't think there's a role, but I think it needs to be a very cautiously and purposefully selected role, and not hoping that AI will be the solution to our problems. Thank you.
Very well said, Catherine. And actually, with that view, the focus of the next dialogue is indeed the role of healthcare workers, the nurses, the midwives, the healthcare professionals who are on the front line and often in very challenging circumstances trying to deliver on the veracity of issues that we are talking about. Before I come to the senior advisor from the Maternal Child Health Department, Dr. Wilson Weir, for his reflections on acceleration, I did wanted to ask, because we have 3 countries from a region which not only has got one of the highest maternal mortalities in the world, but also we are looking at a compounding of crisis that is being confronted, especially if we look at the impact that climate is having on maternal and child health outcomes, particularly issues around heat stress and air pollution. Although the evidence is still emerging and there is a precarity in terms of data that we have heard a lot about both in terms of the need to invest in preparedness and making sure that issues related to maternal child health are included in the packages of interventions that are being designed. I did wanted to have some quick reflections from the panelists in terms of how do they see this compounding of crisis affecting the kind of issues that they are servicing at their country levels, and any ideas in terms of what works in these areas as well. Maybe I can start with you, Catherine, for this, and then end with Zoya. Catherine, over to you.
I'm a little flustered because I was still on the role of the community. So, but reflection on that one, it comes back, for me, the basis comes back to what we discussed before, the lack of what we would like to see, which is resilience. So the need for massive investment into health system strengthening so that when shock comes, the health system is in a possibility to react, or even better, to anticipate. We had a long discussion with a colleague about anticipatory action in SRH. And there's obviously things that we can do in SRH in anticipatory action. The problem is if you don't have a health system in which you can contact your patients, you have patient files, you know what the profile of the affected population is, and you have data on them, then anticipatory action becomes kind of like a gamble because you don't even know whom to reach out to, or you can't even reach out to them. So for me, the basis is really the investment on the longer term into the system, very clear. And I think everybody agrees with that. Now we just have to have the funds to do it. The second piece is, yes, the accumulation. I think the accumulation was probably always there, I dare to say. I think we had a tribal difference, political difference, and then you had a famine on that, and then you had the conflict on it. What we have is new themes. Climate is a huge theme. And what we also have is a better understanding of what this actually involves. I think the understanding of how unproportionately high women and girls are affected by crisis, and then this accumulation of crisis, to say there's poverty, then there's displacement, and with everything that's added on, their vulnerability, the destruction of their social networks, their capacity to self-sustain themselves gets less and less and less. I don't know if any of you have ever done this exercise of a power walk. look it up. It's very powerful to understand what this means. With every step that you do and every event that happens, you get pushed back and back and back in your opportunities. So I think that's what we need to look at when we look at these accumulation of crises, to say there is root causes to GBV and SRH which are the same. And those, together with health system strengthening, we have to work on very seriously, which is still inequity, rights of women, non-respect of women's rights, of human rights in general. So I'm an adamant fan of humanitarian action, but if we want humanitarian action to really do its role and not catch up with the lack of development, we need to invest into development, health system resilience, and we need to once and for all come to terms with this issue of equality, and which is at the base of everything. It's at the base of SRH also. Thank you.
Absolutely. Thank you. Thank you for that, Catherine. Hafsa, over to you. Any brief reflections?
Yes, I'll be very quick. So I think the first thing is we have to walk the talk of intersectionality. I think Katrine highlighted that, but we need practitioners on the ground and just the people who are from allocating resources. So normally practitioners on the ground are very intersectional, but people who are deciding where the money is going, how is it going, where it's going to be allocated, to the policy design, to the program design, needs to have that element. And I think the climate action, when we have emerging data, we have to use that as a foundational base, because we can't wait till it becomes the biggest issue. Because some of the issues, we have been working for years and years while data is progressing, we can't let this happen to it. And I think to understand the polarizing context of what does commitment look like, and are we talking to the right audiences? Because sometimes we have to take this outside the development sector space, those who are already passionate and working it, and to those we hold accountable, and where the financing can come in. So I think prioritizing the financing element, because all of this would not sustain, and then we all fight for a very small pot of money for various different causes. And cross-sectoral solutions, because we know there's a limited amount of money coming in and limited amount of resources. How can we design a program that is cross-sectoral, hitting 2 or 3 targets meaningfully and sustainably? So the sustainability angle has to be really thought about. I'm going to stop there.
Thank you. Thank you so much for that, Hafsa. Dr. Poonam, any brief final reflections from you?
Yes, I would definitely want to talk about engagement of communities to strengthen the public health initiatives, because educating communities about health promoting behaviors and all the social determinants of health is very important, preventive, so they can understand the importance of preventive care. And beside that, empowering of the local organization, involving community leaders, and funding health research to understand the local health issues, investing in training programs. So these are, and of course, developing a robust emergency preparedness plans that can quickly mobilize resources in case of any health crisis. This is what I would suggest.
Thank you. Thank you so much, Poonam. Zoya, over to you for the final words.
Okay, I think my final words will address the questions you have asked about the climate change. So just informing that we already have a national plan for climate change and health. And within that, we're also looking at an adaptation strategy involving the various other programs. So that is the kind of stand which the government has taken, that you cannot have a climate change program without the other health programs. So all of us are a part of creation of an adaptation plan in which all our interventions which will be affected by climate change have to be addressed. So I think we are well equipping ourselves, the whole healthcare system, to address climate change as a whole of, I think, health, at least, health ministry initiative, so that everybody is aware as to what interventions will get affected by climate change and how we can mitigate those risk factors. Second, I would say that I think we have taken another step forward, is that within our own training health programs, we have added climate change as one of the newer initiatives on which we are informing our medical officers, our counselors, as well as our ANMs. So that I think is a good thing, because through informing our own healthcare providers, we reach out to the young people out there, the mothers, the children, whoever, the families, whenever we have our village health and nutrition day. So there are newer topics on which even our healthcare providers are being trained to talk within the communities when they do the outreach activities, when they do the weekly immunization sessions or the antenatal checkups within facilities or within communities. So I think we have started in a robust manner, and I think we'll keep our fingers crossed to see how well we come together as a climate change addressing program intervention for the government.
Thank you so much for that, Zoya, and to all the panelists for that remarkable conversation and a clear call to action for strengthening the interventions that we are talking about, the services, but investing in systems and making sure that issues around inequities and addressing inequalities lie at the heart of what we need to achieve in terms of achieving sustainable outcomes for maternal, newborn, and child health. Wilson, you've been hearing to this discussion very patiently over the last hour. And I would really like to hand it over to you for your reflections and also for what you think the next steps should entail. Over to you, Wilson, and thank you again for joining us.
Yeah, thanks very much, Rajesh, for this. And colleagues, this was a very, very good discussion and a very good panel that really has highlighted what are the issues and where we need actually to be looking. Listening to the discussions and the panelists from countries, it was very clear that where we should be looking is actually try to look at the local situations and address the local situations. We seem to be knowing what exactly we should be doing, but how do we address and bring in those populations that we are not reaching, that we are missing, that we actually need to target? And I think what I've also had good examples of what we can do, how to reach the communities, how to involve the communities, how to use the resources we have in the communities to actually improve the services that we need to provide to mothers, children, and adolescents. I think this is a very good message that we are all hearing from the countries. And therefore, I want to say that our role as UN agencies is really to support these activities, and how can we provide the support and make sure that we can share some of these best practices that are being generated locally in countries to be disseminated to other countries to be able to address some of the challenges that are facing them. I think we all have the same challenges, that the systems, once the systems are not responding to the needs of the population, then we have problems of delivering the services we want to deliver. And I think, as it has been very well illustrated from the various panelists, that there are various areas that we need to address in moving forward. And as such, the UN agencies have actually come together over the last few years through the Every Woman, Every Newborn, Everywhere, as a partnership to create this platform that will help in accelerating the maternal newborn mortality and preventing stillbirth. Although the partnership is led by UN agencies, but it works in collaboration with the development partners and donors to support countries. And of course, you know the targets we have, the 90-90, 80-80 targets, is basically to say we need to ensure that we improve on antenatal coverage at least by 90%, ensuring that skilled birth attendance by at least 90%, and that's well illustrated by the colleague from UNFPA, that we can have AI, we can have this, but if we can't have a skilled birth attendant to deliver a mother, then we shall not achieve our targets that we are looking for. I think this is very, very, very important. And since the UN really is coming in to really provide global advocacy, but also to support the ministries of health in their plans to mobilize not only internal domestic resources, but also external resources to support the national plans in order to accelerate progress. And really focusing on fundamental areas that we think would help to accelerate progress. One area, and I think has been highlighted by a number of colleagues from the countries, is how do you strengthen the services to provide antenatal care, to ensure that there's intrapartum care is optimal and is of quality, to ensure that there's good postnatal care, including family planning, access to family planning, and also ensuring that there's quality care across the continuum of maternal, newborn, child, and adolescent health, including referral systems to ensure that those who need further care are referred and provided care. And of course, we also recognize that even with the newborn, if we have to move forward, it's no longer just looking at providing basic care, but also ensuring that we are building the systems to address like preterm babies. However good we are in managing preterms, we cannot manage them at basic facilities. We need to upgrade the facilities to be able to handle those preterm or small and sick newborns. They will need basic facilities. So we are saying we should upgrade our systems to respond to the needs of these kids. Otherwise, we shall not manage. But also ensuring that there's quality assurance through the system. And I think this is very, very important. And that's where I think, like colleagues have said, that's when we can also think of how can we use new technologies, new innovations to support improvement in the quality of care and of services that we are providing. But all in all, our collective effort as UN agencies is really to bring all these learnings and share them across countries. And I think what we are doing here today is one of that perspective. And I'm thankful for PMNCH to have hosted this dialogue. And I think if we continue hosting these dialogues and sharing some of these learnings, this would be very, very helpful. But having said that, I think we also need to move forward. As we move forward, we need to start thinking about, yes, there are immediate things to solve. There's immediate things to prevent mortality that is preventable. But how do we build not only the resilience of health systems, but the resilience of the population? And that's why in WHO, we are trying to expand the agenda to look at how can we build resilience right from birth, even before birth, that the population that we are having is having optimal health, ensuring that by the time young girls become pregnant, they have reached the age of becoming pregnant, they are healthy and able to actually become pregnant. Or young boys are healthy enough to support their families when they become adults. And I think that's the agenda I just wanted to highlight. And recently, WHO and UNICEF just released guidance around well-care visits that will run across from antenatal period up to 19 years of age to ensure that you are able to optimize the health and well-being of children and adolescents as we go forward. But also realizing that apart from the immediate causes of death that we are looking at, we are seeing changing epidemiology and trying to address some of the new areas that we are looking at, like non-communicable diseases that are also impacting not only the young population, but also mothers in later life in that. And finally, I want to really say that as WHO and UN agencies, we are committed to this agenda, and we are working very collaboratively across to really support this. WHO will support countries in scaling up some of these high-impact interventions, addressing the gaps to care and to access to care, but also increasing accountability. And I think that's where the data, like it was said, is very, very important. Without data, we are not able to know where are the gaps, what should we be planning for, what are the missing levers that we should be addressing. And that will be very, very important. But having said that, I think one of the critical things, and was really highlighted in all countries, is partnerships, working across different sectors, both within government and outside government. So for us to actually accelerate progress, it will need collaboration, partnerships across different levels of the system and across different sectors to be able to support what is needed. If you are referring a mother or a child who needs urgence, if there are no good roads or there is no transport system, then that mother will never reach where they are going. So we really need to open up and look across to do that. So WHO as a technical partner looks forward to working with the PMNCH and other partners to actually to support the acceleration of the progress towards maternal, newborn, and child mortality reduction. Thank you. Back.
Thank you. Thank you so much, Wilson, for that and for laying out some very clear and concrete action and next steps. My sincere thanks to all the panelists and to you, Wilson, for joining us today. We have gone over time, and that shows the richness of the conversation and the dialogue that we had. As I mentioned, this is the first in a series of dialogues that we as the partnership are looking forward to organizing. Join us, please, for the next one, which will take a deeper dive and look at issues around health workforce and what do we need to do in terms of strengthening the health workforce capacity to deliver on the maternal, newborn, and child health agenda. Many thanks to you all again for joining and for all the work that you do. Have a good rest of the day wherever you are. Thank you. Goodbye.
Thank you. Bye, everyone.
Thank you very much. Bye,
Thank you.
everyone.
Bye-bye.
Rajat,
Bye.
will you share the recording?
Yes, yes, we will.
Thank you. Bye.
Thank you, Rajat. Thank you.